What screen can you all see right now?
Yours, it's pulled up.
Like the Canvas?
Yeah.
So this is like, it's considered a quiz. This is like a little worksheet, but it's considered a quiz. The website calls it a quiz. So it's not really like a test. All right, so I'm going to email you this conversion chart for ounces and milliliters and stuff. It's nothing major. And then you've got Chapter 6, Chapter 7 exam due tonight. And then there's 2 little assignments here that are due tomorrow night. The deadline's for tomorrow night. You can do them tonight if you want. And here's some supplemental stuff for you. You can look at, oh, there it is, the conversion table. Wanted everybody to look at this. So these are some good conversions you'll need to know, especially for your certification exam. And I'll make this, we'll talk about this, we'll make it easier to look at. But when you are measuring the input or intake and the output of a resident, meaning how much they drink, how much urine they produce, we measure that in mLs. You need to convert some ounces to mLs.
Okay.
Print this for myself. So let me go along in the book here. All right, so what's some vital signs we can take on someone? How can we measure?
For their pulse, you can do multiple different places, but the wrist is one and the neck here is
You know
one.
what the name of that wrist one is?
Radial?
Mm-hmm. Well, what's going on? Pulse. What's another one?
I know it starts with a C. It's up here. I forget what the actual.
That's another pulse. What's some other vital signs we can take?
Oh,
we'll talk about the different ways to get all these here in a minute.
Temperature, body temperature.
Temp. Whoa. Yeah, there's a tons of different temperatures we can take.
Mm-hmm. Respiration and then blood pressure.
Yeah, respirations. Blood pressure. We're missing one up here. We can take.
Is it the level of pain? I think is what the book has.
O2 sats. Yeah, and then pain is considered a vital sign as well.
That's surprising. I didn't know that before this.
Yeah, some places are like that. Some aren't. We'll talk about how to document that. So we're going to learn what we're taking and what's going on with these. What are some normal ranges and some averages here. So part of your basic nursing skills is being able to take vital signs and take them accurately. And you're going to be required to take vital signs on your skills portion of your test. That's a guaranteed. That and hand washing, the other 3 skills are random that they'll choose. Let's talk about temp first. So what can make our temp change here? What's some things that can make our temperature fluctuate?
I mean, like
how cold we are.
Say it again.
How hot or cold we are.
Just the environment. Infection's one of them, right?
Mm-hmm, like fever, sickness, stuff.
Infection or illness. There's a bunch of other stuff. What else?
Mm-hmm. Does age play a difference? I mean, I know the average is set, but I don't. That's probably not true. But
age is a big factor in it. Babies' temperatures are a lot higher than elderly.
That's what I thought. Okay.
Yeah. How about time of day? We got something called.
Yeah, I hadn't thought about that, but that's true.
Temperature is usually lower in the morning than it is in the evening.
How much of a difference will there be in like a person throughout the day? Because I mean, not too much, not that much.
Degrees.
Okay.
A couple degrees. If you're pregnant.
If someone has a sorry, I didn't mean to cut you off.
Go ahead.
So you said it's higher in the beginning or lower in the beginning of the day?
Usually lower in the mornings.
So like if someone has a fever of like 101 in that evening, but like the next morning they have it of like a 99 or 98. Is it still considered like that they're sick or?
Well, you would take other things into account like their symptoms, but we're going to talk about the numbers where it cuts off and it's an actual fever versus just a regular temperature here in just a second. That's a good question. Emotions like crying can raise our temperature. So that pretty much covers the big factors here. So where can we take a temperature at? We can take a temperature under our tongue, right?
Yeah.
Oral temp. We got a tympanic, which is our eardrum. That's the tympanic membrane is our eardrum.
Mm-hmm.
If you've ever had a thermometer stuck in your ear, it's bouncing a laser off of that membrane and reading it back.
Temple is one.
Mm-hmm. Axillary or armpit.
The mouth sometimes.
That's the oral one here.
Oh, yeah. Sorry, I didn't see that. Sometimes the rectum is used.
Rectal is the most accurate. And this temporal is measuring the temporal artery here. And so if you look in your book, you'll see there's an average, like these are all good places to read a temperature, but there's differences in them for a normal human being. Like you might read my temperature here and then here, and there might be a difference in it. Well, any thermometer that you choose, like usually you have to push a button a couple times to say, I'm going to take an axillary versus an oral. And it will automatically adjust for these differences. So don't get caught up on these differences in where these temperatures are taken at. Because usually the thermometer takes care of that for us. And very rarely will we ever be using one of these glass ones that you see on the next page here. I'm not even going to worry about those. But the average temperature, which everybody pretty much knows, is 98.6 degrees. This is not a normal temperature. It's just the average that we measure in human beings. Okay, you might have a normal temperature of 95.8 degrees for you individually. But this is the average. If you were to measure all human beings on Earth, it would average out to be 98.6. Now, I have read some literature that with global warming and stuff, this has actually gone up like 98.9 or something, or 99 now.
Huh.
You know, FYI stuff. But
Yeah, that's cool.
On the test, would it be, like if that was a question, would it be 98.6 or 99?
98.6. Yeah, let's just go with what this book says. And the book doesn't really get into it too much, but it does talk about how your temperature can fluctuate with the time of day and some of these factors going on here.
Mm-hmm.
But I don't think it even gets into what's a fever or not. See, like there's all kinds of different ways you can measure a temperature that my MAs have to learn. But there's a couple of reasons why you wouldn't take some of these temperatures here. So one reason why you wouldn't take an oral temperature is if somebody just had oral surgery, for example. Because if they just had oral surgery and they're having some swelling and increased blood flow in that area, it's going to raise the temperature there, and you're going to get an inaccurate reading. So you'd want to do something different, like an armpit or an axillary. You don't want to do rectal on, infants younger than a certain age, like I think 1 year or less, because it's dangerous for them. And then maybe patients who are in hospice care, you would be taking rectal temperatures to get an accurate one. But I think that's one of your questions about the oral temp. Like, why would you not take an oral temp on someone? One, because if they've had oral surgery, that could make a difference. And then if they're unconscious, it's another reason, right?
Would they have like a different mouth temperature if they're unconscious? I mean, it makes sense just because they're not, but would the actual temperature be different?
Yeah, it could be, because if they're just doing a bunch of mouth breathing, it can change it.
Gotcha.
Probably negligible, but
Mm-hmm.
Is there one of these temperatures that like is known for not being accurate?
No, not really. They're all accurate enough for me. Let's see, unconscious oral surgery, and then they say kids younger than 5 years old, you don't want to take an oral temperature on them. This is like a no. This is with a slasher, don't do that. Likely to have a seizure. That's kind of gimme. If they've drank or ate anything within the last 20 minutes, you don't want to take an oral temperature because even room temperature water will lower that enough to be way off.
Or which one?
Oral temperature.
Okay, gotcha.
So no eating or drinking within 20 minutes before you take an oral temperature as well. Book says 10 to 20, but I'm just going to call it 20. And you'll probably never be using anything other than a digital thermometer. So I wouldn't sweat the glass thing. Any questions about that so far? Let's talk about pulse. So somebody already mentioned, I'm going to use red for pulse. Somebody already mentioned radial.
I can like point to where they are, but I forget the like exact names of them.
All right, let's see what you got. Point some of them.
There's one here. There's one here.
Hang on a second. You got brachial in your arm, and then the one in your neck is carotid. What else you got?
There's one you can get on your foot. Is it there?
Yeah, pedal pulse.
Your femur. Can't you get one on your
Femoral pulse. And you got popliteal, which is behind your knee.
Yeah.
And then there's even apical, which is at the apex of the heart here. You take with a what's that thing called? Stethoscope. But these are probably your most popular ones that you all might be working on. Okay, radial is called radial because this is your radial bone on your thumb side, and you're taking pulse from the radial artery that's on that side as well. So a normal pulse, does anybody know what that one is?
It's like around, I always have a low pulse, so mine's like usually around 70 or 60, but in between that and like 100 or 80.
It's between 60 to 100 beats per minute is a normal pulse. If it's 60 or less, it's called bradycardia. That's an R in there. And if it's greater than 100, it's called tachycardia, just like a tachometer in a car. You know that arm that goes when you floor it?
Yeah.
Okay. Now, if you sit down and take my pulse and I have 110 pulse and I look like I'm normal, you're not going to hopefully have a cow over that. Some people might be a little bit higher. They might have just had something happen that raised their pulse. So what's some things that can raise our pulse?
Fear, like getting scared, or
Yeah, emotions, crying. Again, the same things up here.
exercise.
Huh?
Exercise.
Exercise or exertion. Wait a minute. Let me start over on that word. Exercise. What else?
Kind of like all those same things, like time of day or age or things like that.
Time of day. Age. How about pain level?
Yeah.
Can make your pulse go up, right?
Yeah.
What about infection or sickness?
I think so, yeah.
Yes, definitely. Okay. low oxygen, all kinds of stuff.
Mm-hmm.
All right. So let's talk about well, this will all come together here in a minute. Where's my orange? Let's talk about respirations. So what constitutes a respiration? One inhale or one inhalation and one exhalation equals one respiration. Does that make sense what I'm saying there?
Yeah. You need the in and the out to count as a unit.
That counts as one breath. And so some things you can, well, we'll talk about that here in a minute. Same things are going to kind of affect your respirations, one being infection, okay? Age, maybe not so much, but emotions again, exertion, maybe disease or illness. Like COPD or pain. Okay, normal respirations for an adult are 12 to 20 breaths per minute. Normal respirations. Anything less than 12, and I don't think you need to know this for test purposes, anything less than 12 is called bradypnea. Anything greater than 20 is tachypnea. Notice a theme here?
Yeah.
We got words like hyperpyrexia for temperatures of 104 and greater. Pyrexia for temperatures of like 101 and greater. Hypothermia for temperatures less than 95 or something. But your book's not going to ask you about those. You're not going to be asked about it in this course.
For the trachopnea, I think is how to say it, for the respiratory, is that if you're resting breath, like resting beats breaths per minute is over 20, or is that like anytime?
Anytime.
Okay.
So if I just got done running a marathon, I might be tachypnic for a while.
Okay. Gotcha.
It's tachypnea. You've heard of the term apnea, right?
Uh-huh.
So it's the same suffix on here. This is A means without.
Mm-hmm.
Like if you're afebrile, means you're without a fever. Apnea, meaning without breaths for a few minutes.
Okay.
Medical terminology. All right. Let me go through these last two real quick, and then we'll talk about blood pressure. So O2 is oxygen saturation. And if you remember, you got your red. Did we talk about red blood cells or not? I don't think we did.
Yeah, I don't think so.
I'm going through circulatory system with my MAs. I'm getting my classes mixed up. So you've got a red blood cell that is a sort of like a disc. It's biconcave, meaning there's not a hole in the middle of it, but it's kind of like a depression. If you were to look at it from the side, it would have its middle parts kind of cave in like that, right? You know what I mean by biconcave?
Yeah.
Instead of being curved outwards, it's curved inwards on both sides. What that does is increase the surface area of the cell by having that depression in it. Think of a pull inner tube without the middle cut out. And the reason it needs that surface area is because it has these molecules on top called hemoglobin. You might remember this from your science classes in school. There'd be like 4 of them on each red blood cell. these little proteins on here called hemoglobin. They have an affinity for binding oxygen and binding carbon dioxide, which are some of the waste and nutrients that our cells need. And they're better at binding carbon dioxide than oxygen. But when you put the little O2 sat meter on someone's finger, what it's doing is shining a laser, and that laser is bouncing off of hemoglobin and coming back into the machine, and it's averaging out how much hemoglobin it's reading, and therefore giving you an average of how much oxygen you can carry. It might, the way it shines back might change depending on if there's actually oxygen bound to hemoglobin. I'm not sure, but it's kind of, beyond the scope of this practice. But that's what we get when we get an O2 sat. And so you can either be 100% saturated with oxygen, or you can be less than that. Anytime somebody gets less than 92 is when we kind of get a little excited or concerned for our patients, if they're not usually that low. You might get some COPD patients or chronic obstructive pulmonary disorder. They might be in 80s all the time with oxygen. And if that's what their average is, I'm not going to get too excited if I see that. But if I walk into a room and see someone kind of hungry for air, I see signs and symptoms of like nasal flaring. If their nostrils are flaring out, that can be a sign of oxygen hunger. Or they're heaving and saying, I'm short of air, I can't breathe, I have something on my chest. I want to take their oxygen saturation. If they're low, then that's going to tell me something's wrong. Okay, so, and usually these machines, they'll take a minute to catch up to what the actual reading is. So if you put it on and it says 90, just wait a minute and it'll come up to where the actual reading is.
What's the average again?
Well, what we want to see is 100 for people.
Okay, gotcha. I didn't know if that was like normal though, or
yeah. If I put one on, it'll say 100 for me and you and most everybody, except for those with like chronic pulmonary disease. And if I hold my breath, it'll take a minute for it to dip down to like 92 maybe, and then once I have to breathe, it'll come back up.
Gotcha.
What was so I guess we talked the fever. What is the number, like if you actually have a fever, what is the number above?
Okay, so for fever, let me see if I can remember this right. We got 96.8, which is normal or average adult temperature. That up to 99.1 is a normal temperature. And then, 99. No, I'm going to say 100.1. I'm sorry. Say 101 is a normal temperature. And then 101.1 to 104 is fever or pyrexia. Sort of like you see that word pyrex, like your glassware can get real hot in the oven. And then anything of 104 and greater is hyperpyrexia, or like, holy crap, we got to get this person to the ER right now type temperature. Does that answer your question, Hannah?
Mm-hmm, yeah.
But you probably won't be tested on that stuff. I don't mind telling you, like, I'm happy to answer any questions you got. Let me look something up real quick here. Make sure I got those numbers right. Terminal thermoreceptor. It'll bug me if I don't know it anyway. Fetus fever. Oh man, I'm just in the dictionary, not the index. 355, 356.
Hi.
Bless you.
Thank you.
Yeah, so like just for an example, a newborn, their average temperature is 97 to 100 for axillary. For a 1-year-old, it's 99.7 is their average body temperature, because babies have a much higher metabolism than we do. Their heartbeats are anywhere from 100 to 120. Fetal heart rate is 120 to 140. And a newborn is 120 to 140 or so. And with higher metabolism comes higher temperatures. So the numbers it gives me here are, let's see, anything 93.2 or less is fatal. 97 or below is hypothermia. This is a core body temp, right?
So you can almost live better. Like if you're like you can it's almost better to have a high temperature versus a low temperature.
I don't know. Like you think about the kid that fell into the frozen pond and stayed there for 30 minutes or an hour and lived.
What?
You ever-
I did not know that was a thing.
oh yeah, there's stories about people falling in frozen ponds for like an hour and coming out just fine
What?
because of the cold water preserving their brain and shutting down their metabolism.
I thought that's when you died of hypothermia.
Well, normally people do die of hypothermia, but there's a few instances where that's happened. But you don't hear anybody surviving a fever for longer than a few period of time because proteins start to denature, and just like people say, your brain like basically scrambles. So I'd say lower temperatures, you got a better chance of surviving because your body can fight lower temperature with the shivers and shutting down blood supply to extremities and making your internal organs warmer and stuff a lot more than you can to cool off. 99 to 100.4 is a low grade fever. That's where I was messing up at. And then 100.4 to 105.8 is pyrexia. And then 105.8 to 109.4 is hyperpyrexia. And then greater than 109 is fatal.
109 is incredibly high already.
Yeah, and people who are dying or in the dying process, their temperature will be all over the place. And then there's periods of a fever, like you've got a continuous fever and an intermittent fever that will break and then get higher and break and get higher. And depending on what the sickness is and stuff, those fevers will be, you'll see those type of patterns present. So like those nurses in the ER that come in and take your temperature every 2 minutes, especially if like a brain injury or something. You got a brain injury, your temperature is usually fluctuating all over the place when you're in that critical mode. There's a reason they're in there taking that temperature because it tells them a lot about what's going on internally, like your hypothalamus and stuff. Anyways. So I talked about O2, and then I've talked about pain a little bit. So before we get to blood pressure, some ways we can describe these. Remember the objective information stuff we talked about?
Mm-hmm. Yeah.
So some ways we can describe these, like pulse. We can use words to describe these pulses. Don't just say they got 88 beats per minute. There's some ways you can talk about that. You can have 88 beats, but it can be weak or thready. Or on the other hand, it can be bounding. Ways to describe a pulse that are objective. Okay? Everybody can pretty much agree on what these words mean. And these are words I would use as I'm charting. Respirations can be even, meaning as we watch their chest rise, both sides are rising equally. Because if only one side's rising compared to the other, what does that tell me about their lungs?
They're not working together, right?
Yes, something's wrong. There's either a collapsed lung or a pneumothorax or something like that. It can be even, or unlabored, meaning they're just breathing like normal, or they can be labored. Okay. And then pain. Or what's some ways we can describe their color? So somebody who's low in oxygen, what are they going to be looking like?
Pale.
Okay, they might be pale. They might be cyanotic. Cyanotic. Sorry, I promise.
I can't spell anything, so I cannot help.
I'm a horrible speller.
I worked with Dr. Hody. He's a neurosurgeon, and one day he said that like spelling is a lower form of intelligence, and I've used that excuse ever since. Cyanotic. We'll do that one. That looks good. Meaning they're blue, right? You can have acrocyanosis, meaning their fingertips and their toes might be blue, or they just might have blue lips. Okay. Acro meaning like an acrobat is kind of the Greek term for your limbs, because they use their limbs to swing around. Give me some other words. Like, say I come in to you and I say, hey, my patient's not looking too good. What's some better ways I can describe that?
Would they be pasty?
I would say pale if you're talking about color. Now, if they're sweaty or breaking out in a cold sweat, I'd say they're diaphoretic. Meaning diaphoretic. This is a medical term for sweating. They could be clammy, cold, sweat, skin. But give me some other terms. What might somebody who's having an episode, you might have a decreased level of consciousness, right?
Yeah.
It could be lethargic. They could be confused. And if they say they're just not feeling good, I'm going to ask you, well, what exactly was wrong with them? They have a stomach ache. They have a headache, a fever. What does that headache feel like? Is it, a squeezing pain? Is it a sharp, dull, aching? No matter where they're telling me about their pain, I want to get some descriptors in there and rate it if I can. So you want to try to be objective when you're reporting vital signs to someone. And when a patient tells you, I just don't feel well, rather than go to the nurse and say, well, this patient doesn't feel well, get some vital signs, get some objective information, and get some more descriptors from them so you can go to that nurse with something a little more substantial,
Yeah, that makes sense.
There's nothing outside of your job description in gathering this information and taking these vital signs on these patients. As part of your job is to figure some of that stuff out. So BP, how does BP work?
Beats per minute?
No, blood pressure. Blood pressure. So it is 120/80. Let me zoom in here. How does blood pressure work? It is 120/80 in terms of the numbers. This is usually what you see is this number is bigger than this number. And this is systolic number. And this is diastolic. And so what does systolic mean? It's when, if you got your heart here, I'm going to draw a little heart. The pressure inside of these chambers and your vessels coming out of them, the pressure is the greatest on the walls as you're reading this number right here. And then diastolic, the pressure is least greatest on the walls. So I'm pointing arrows inwards this time on these vessels and things like that. Well, how does that work? How do we get those numbers? Well, I'm going to try to explain it to you here. So, anybody heard of something called laminar flow?
I think I've heard the term before, but I don't remember what it is.
So laminar flow is if I took, imagine you turn a water hose on, and you turn it on full blast and you just let it run out. Well, that water that comes out, it's real smooth and glassy like as it comes out of the end of that hose, right?
Yeah.
Almost looks like a piece of glass coming out. It's like think of a smooth laminate countertop. The sides of that water is real smooth and solid. So the water inside is doing this number right here. But if you got something called turbulent flow, or if you were to squeeze that water hose, that water would start swirling around in there and get all frothy, right?
Yeah.
Well, that's not laminate flow. That's turbulent flow. So we've got the difference between these two words now, laminar and turbulent flow. So inside of your vessels, you've got smooth muscle in there. And a real smooth inner lining where blood cells like to glide over that. And if you have any kind of defect in your heart valve or something like that, those red blood cells like to swirl around in there. Sometimes cause a clot. That's why heart valve defects can be a problem for blood clots for people, because once those red blood cells start swelling, they think, oh, we need to clot. There's a problem going on here. So that lining needs to be real smooth so you get that laminar flow in there. And there's great pressure in your vessels, right? Mm-hmm. If you were to injure an artery, it would spray 30 feet across the room. So when we take a blood pressure, we're taking this artery in our arm and we're squeezing it closed. And you got blood flowing in here, right? Real smooth laminar flow. We start to close that cuff down on your arm and it gets kind of tight, until eventually it's shut off. And there's no blood flow going through there for just a brief period. And then all of a sudden the nurse lets the out and you start feeling it thump, thump. Well, as that vessel opens up, the first blood to squirt out of there is coming out with such a great force, you can, feel it in your arm and you can hear it through the stethoscope. And that first squirt to come out that hits the walls of that vessel is now turbulent. Mm-hmm. And that first time you hear it is the first number. That's where we get systolic from. That's that whatever number that falls on is the pressure at its greatest as it's hitting the walls of the artery.
Yeah.
And so we keep listening to it as the valve opens and this vessel slowly opens up more. And it's still squirting until finally it opens up and it's patent again and we don't hear it anymore because it went back to what?
Gotcha.
And is there not a pulse there? Is that why you don't hear it?
You can't really palpate a pulse in here for an adult. You take pulses here on a baby. You could probably get one if you really tried.
Okay, gotcha. It's just not, you'd have to press hard or something.
Yeah. But as you hear, and until you hear it, until it stops, that last number before this finally opens back up and that smooth flow happens again, that last number you hear is the diastolic. And that's where we get those two measurements from. And we measure them in millimeters of mercury. This is the chemical symbol for mercury here. So let me get a picture open here. You can see right here, we got millimeters of mercury. Whoever invented the Sphygmed manometer, the blood pressure cuff, decided to measure it in millimeters of mercury. Some German guy, I'm presuming. But, we'll pump it up until its artery is cut off. And then it'll be falling, and maybe we'll start to hear it right here. And that last number we hear it at, that's the diastolic. So when you're taking a blood pressure, you got to watch for when you hear it, when you don't hear it again. Mm-hmm. And we'll get practice on that when we get together in the lab.
Great.
If you don't have a blood pressure cuff at home, you're welcome to start. You can try it. It's not really hard to do or anything. But it takes a little bit of practice to learn what you're listening for, to get stuff positioned correctly and things like that. So when you take your test, you've got an error range here for these readings you can take. So I might set my little machine and I'm testing you on it. What is it doing here? At 120/80. And so I would expect you to get a reading somewhere in this range here. Well, you've got an error. You can go plus or minus 4 for this number, and you can go plus or minus 4 for this number. So if I'm looking for you to get a reading at 120/80, if you see these little hashes on here, these are every 2. So 120, that's 118, 116, 114, 112, 110. Then 2, 4, 6, 8, 100. So you should be getting, first of all, a reading that's even numbers when you give me a reading. And you've got an error margin, so you can get this number between 124 and 116. If you just get a number somewhere in there, you'll be right. And then down here for 80, you got 184 and 176. If you can just get a reading somewhere in between there for the bottom number, you'll pass. Does that make sense what I'm saying?
Yeah.
I'll go over this again with you. We're in person. Like it's not a, don't worry if you don't get all this right away. But one of the assignments you got to do tonight is look at this dial here. Like what reading is number 12 here giving me? What's it pointing at? Can you see it good enough?
It would be 130.
That's right. What about 13? That's 134. 136, 138, 140. So I'm just,
Do people report those mercury numbers much?
yeah, that's what any blood pressure you get is understood as millimeters of mercury.
Gotcha.
Whether it's on a digital cuff or whatever, it's 120/80 millimeters of mercury is kind of understood after that.
Okay, what's the number 13 then?
Where do you see that at?
At 120, at 134.
So this is an assignment. I might ask you this is a picture from an assignment.
I got you.
Say,
Okay.
what's reading number 21? And you're supposed to tell me 2
Oh,
things.
that makes sense. I thought that was some other. Okay, gotcha.
And this is actually the picture you'll see on one of your assignments tonight or tomorrow night
Okay.
when you do it. Okay. Hannah, you got that?
Yes.
Any questions?
I think I'm good.
Okay. So we talked about vital signs pretty thoroughly here. Got a few more minutes. I wanted to tell you about some of these different places to take a pulse that Hannah was telling me about. Real quick before I move on. So we did have a radial carotid. This is your carotid artery up in here. Usually this is only used for emergencies because if you take a pulse too long here, you can, cut somebody's blood flow up to their brain. Why do you not want to take a pulse with your thumb?
It has less touch sensors, doesn't it?
It has its own pulse in it.
Oh, gotcha.
Thumb has its own pulse in it. You can feel it if it's throbbing enough or somehow, but you always take a pulse with 2 or 3 fingers.
Mm-hmm.
Okay, whether it's here, anywhere else. You never do a thumb. There was the brachial, but it's mainly used in babies. Femoral artery, popliteal behind the knee, and pedal pulses in the foot. And so why would I care about taking a pulse down here, do you think?
If they have like some leg problem or something and you're trying to make sure that they have circulation.
That's right. If I see swelling on both of their feet, I want to make sure they're getting good blood flow down here, so I'm going to check their foot. Or if they had a hip replacement surgery, I might want to check the pulse down here to make sure there ain't nothing blocked, right?
Yeah.
Or if I go in and I see a foot that is pale and blue looking and cool to the touch, I'm going to get a little excited about that because there's probably no blood flow to it. So I need to go back out and find out where I can feel a pulse at, see where it stops. Especially people with edema and swelling in their legs, it's like you're going to see a lot in your field of work. You're going to be assessing for these pulses and seeing how bad that swelling is,
Mm-hmm.
how much edema is there and things like that. Okay. Just wanted to get that in there. Talk about blood pressure. Let's talk about these. Talked about the pain scale sort of already. The pain measurement scale. I'm not going to beat that to death. What's some signs and symptoms of pain?
You mean like
Aggravation.
how the patient acts or like just what they look like?
What are you going to do, Hannah, if you hit your thumb with a hammer?
Probably go red or pale and not want to talk to anyone.
You might cry. You might have some grimacing, facial grimacing. All right. You might be vocalizing. Ow.
Angry.
Vocalizes pain. Yeah. You can be agitated or mood swings, things like that. Crying, groaning, signing, grinding teeth, increased restlessness. Remember we talked about Alzheimer's patients pacing back and forth.
Uh-huh.
Decreased appetite is a symptom of pain. Guarding, meaning like if you're trying to take off their clothes, but they don't want to pick their arm up and trying to protect their arm.
Mm-hmm.
Rocking, pacing, difficulty moving or walking.
Sometimes also if like I get injured really badly, I just go into shock where like it's hard to talk or anything like that.
Yeah. That's more like a immediate emergency type pain. You know what I mean? I'm thinking more of think of the woman giving birth. She's like, oh, making a big show, you know?
Mm-hmm.
Or like if you're in shock, then that's a whole different story, you know? That's like we gotta do something right now for this person.
Yeah.
I'm talking about you assessing someone who says they're in pain. How are you going to describe their pain? But shock is one. Yes, you're right. So some other vital signs you can take are height and weight. The only thing I'm going to tell you about weight is if they're in a wheelchair, you're usually going to roll them up on a scale that looks like this.
Gotcha.
And to do that, you have to weigh them in the wheelchair first. Go put them in a chair or bed and then go back and weigh the wheelchair by itself and subtract that from the weight overall. And then you'd have the person's weight. Does that make sense what I'm saying?
Uh-huh. Yeah.
And before you weigh them, you want to tear it or make it as 0.
Mm-hmm.
Some people have never heard of this concept. Some scales you have to 0 out so you get a flat reading before you weigh them because it can kind of be off from the previous reading. And then height, it's easy. If you can't stand them up to measure the height, there's a couple different things you can do. You can take a wingspan height. So if you measure somebody's fingertips to fingertips, this is very comparable to this height right here. It's pretty much the same, believe it or not. So if I got a person that can't get out of a chair, can't get out of a bed, I can measure fingertip to fingertip and have their height that way. And that's a very valid measurement to use. I can lay them down on the bed and make a marking on the bed sheet or something with a pencil and measure that, like they do babies. Because babies are usually wiggling around. It's hard to get their measurements. Like I said, you might have to measure the weight of a patient every month at least, and then some who have congestive heart failure or fluid imbalance issues, you might have to weigh daily. And sometimes they can gain 1 or 5 pounds or more of fluid overnight, and that's usually an emergency or something we got to do something about really quickly. Intake and output, last part of this. So here's how I usually break it down for people. Who's got their phone with them right there?
I do.
See how much one of those milk cartons you get in school, how many mLs are in that for me?
Okay.
It's a pint, I think, or half a pint.
I think it's half a pint. Half a pint. I have to walk real quick, so I'm just going to stop my video, but I'm listening.
Okay. So Hannah, a typical glass, like if you go grab a glass out of the cabinet, they say you're supposed to drink 8 ounces or 8 glasses, 8 ounces each of water a day. typical 8-ounce glass has 240 mLs in it. And this is what we're shooting for, to be able to measure in milliliters. Okay. Stop me if I'm going too much into depth here, but a milliliter, so in 1 liter, there is 1,000 milliliters. You know how big a 2 liter of Pepsi is, right?
Yes.
So there's 2,000 milliliters in that.
I need to write this down.
You can print this out too. It's on the website for you.
Okay.
I'm trying to just give you everyday examples.
Yeah.
You can relate this to it. Don't sweat it if you don't remember everything today.
My brain's kind of dead by this point.
Well, this will be on YouTube for you. You can rewatch it later if you want. Plus, we'll be in class together. We'll go over it again. But if you can just remember, like, let me go grab one here real quick.
So tired. Oh, my phone.
What'd you figure out, Mary?
What?
What'd you figure out about the milk carton?
Oh, I'll check again. I'm pretty sure I thought it was half a pint.
All right, so in 1 milk carton or half a pint, there's 240 mLs in that. In a typical glass, an 8-ounce glass, there's 240 mLs as well. So
It's 1 cup, so it's 8 ounces.
in 1 cup is 8 ounces. All right, so if you can kind of get that down, well, if there's 8 ounces in the glass, 1 ounce is equal to 30 mLs. Don't let this intimidate you. Don't make it harder than it is. It's not hard. Okay, so if I have a patient that drinks 1 milk carton for dinner, I can mark them down as 240 mLs. Or if they drink half of it, I think it's about half that's gone. Then it would be 120. It's all even numbers, very easy to add up here.
Mm-hmm.
Usually in the dining room of these nursing homes, they'll have cups that are all 120 mLs each. So you can look at it and say, okay, they drink 120 mLs of water, and they drink their whole milk. So that was 240. And then for dinner, they had 360 mLs total. And you might be tasked with recording what they've drank in a day. So you would have to do breakfast, lunch, and dinner. All right, so we'll say they drink 360 for breakfast, 360 for lunch, and 360 for dinner. But in between, they had 120 with their pills they take at mid-morning of water. And say they had a Coke, which was 355 mLs as a snack. Okay. So somebody who's on 1,000 ml fluid restriction, and they're only allowed 1,000 mLs a day, they can go over that really quickly, right?
Yeah.
And it'll make a big difference for them too. If they're on fluid restrictions, it's for a reason.
Do they ever have dehydration because of fluid restrictions?
Mm-hmm.
Huh.
No, usually it's because they got too much fluid. They're swelling, they have edema, and congestive heart failure and things like that, or kidney failure.
Okay.
Some of your kidney failure patients, some of your heart patients will be on fluid restrictions.
Gotcha.
And so these patients we have to monitor really close. And that's why it's important that we know how to record their intake.
Mm-hmm.
Now, a cup of ice cream makes a difference too, because ice cream is considered a liquid. Okay,
Gotcha.
so on your paper here, it says 1/2 a cup is 4 ounces. And so 4 ounces or 1 ounce is 30 mLs. 3 times 4 is 120. So if they had a cup of ice cream for lunch too, I need to add 120 mLs in there. Say they had a popsicle or sherbet or some kind of frozen treat like that, or a protein shake, or some chicken broth. All that's fluid that has to be accounted for. Okay, ice cream's considered a liquid. And then in the evenings or throughout the day, if they have to have their measurements for their output, we'll either have them pee in something called a top hat, which is just like a bucket that goes in the toilet that will catch urine. We'll be emptying their catheter bag, which will have markings on it. And so if we see, this might be 1,000 mLs here. If we empty 1,000 mLs out, we'll go record that in the book. And it should equal out. If they had 1,500 intake in the day, by the end of the shift, we should have seen 1,500 output.
Gotcha.
So this is why intake and output recording is important. Okay, so just to recap, one 8-ounce glass, like a regular dinner glass, is 240 mLs. That's equal to 1 pint of milk, 1 carton of milk. And 1 cup of ice cream, or like a measuring cup, is also equal to 8 ounces. And since we know 8 ounces is 240 mLs, we know that's 240 mLs. So if they eat 1 whole cup of ice cream, they're basically drinking 240 mLs of fluid. I know I'm going kind of fast here. When you get in that assignment online, it'll give you an idea.
Sounds good.
Okay. And so you might see something that tries to trip you up, like they had 2 ounces of ice cream and you'll need to convert that to mLs. But just look at this paper that's on there, print it out, or write it down now if you need me to write it out for you. Any questions?
I think that makes sense.
It's okay if you forget it. We'll go back over it again.
Sounds good.
All right, we'll talk about, everybody knows oxygen's really flammable, right?
Mm-hmm. Yes.
You don't light a candle or something in an oxygen room. We'll talk about the rest, like changing beds and catheter care when we're person to person, because we'll actually demonstrate that together.
Okay.
So,
My Nana, actually, who lives with us, actually uses a catheter. So me and I have both done catheter care before.
okay, good. You'll be naturals. That's one of the more difficult ones to mess up when you're testing. So you'll be way ahead of the game already. So let me ask you a question here before we adjourn. I would make sure I knew which temperature site is considered to be the most accurate. You might have to go back and look in your book for that. I think it was rectal, but I'm not gonna be 100% on that one. I'm looking at the test. I'm asking you questions from it right now. I'm giving you hints.
Gotcha.
Okay, thank you.
Where should the call light be placed when you leave the room for the resident?
The what?
Touch
Call
it.
light.
Oh.
The light they push to let somebody know they need them.
It's like where they can access it very easily.
Within reach, right. If you look, that's at the end of all your skills too. Call light should be within reach. It's a critical step usually.
Gotcha.
What I meant to mention was too, I forgot to talk about, is these vital signs, you might be asked to take them on residents who are newly admitted to the facility. So if they're brand new onto the floor, you might be asked, hey, go greet our resident, make sure they got what they need, they know how to use the call light, and get some vital signs on them for us. Get their initial height and weight too. Here's another question about rectal temperatures. I would go back and look at that section real quick. What's the most common pulse that we take?
Radio.
Radio.
What's normal breath range for adults?
12 to 20.
There you go. Miriam or Hannah, what's normal pulse for adults?
60 to, he said Hannah. He
Hannah.
said
I meant to say Hannah.
60 to 100.
There you go. What's hypertension?
High blood pressure.
Yep. Are you ever supposed to remove or insert a catheter?
No.
Nursing assistants should never remove or insert any tubes. You can care for them. You can secure them. You can monitor them, but you can't remove them or put them in. If you had to guess, how far should a tympanic thermometer be inserted into your ear? You think 1.5 to 2 inches would be accurate? That's like my whole finger.
Too
No.
much.
1 inch? Probably not. 3/4 of an inch?
Sounds more reasonable.
How about 1/4 to 1/2 inch?
That sounds best.
That's better. Go back and review not only rectal temperatures, but collecting your urine sample. So page 192 and 193. 194. Make sure you look at those before you take this test.
Okay.
How many milliliters is 8 ounces equal to, Miriam?
240.
All right. You guys are good to go. Talks
Thank
about
you.
restraints, a couple things about restraints on here.
Oh, I was going to ask about class tomorrow.
Yeah, what's up?
We can't do anything after 3:30, I'm sorry to say. But if we need, like, if you guys can't, we could do the recording or something.
Okay. Let me think about that. I might, if I've got a recorded class for that chapter, I'll do it.
Okay.
I'll make a recording and we'll just skip that chapter and catch up with it the next day.
Okay.
It's Thursday and Friday. I've got lab, so I'll need to do late hours on Thursday and Friday.
Okay. I think it's just tomorrow that.
So if we met at like 1 or 2 o'clock tomorrow, you all could meet with no problem.
Yeah.
Mm-hmm.
Is 2 o'clock okay?
Yes.
All right, let's plan on meeting at 2 tomorrow.
Okay.
I'll make sure we get out of there within 60 minutes for sure.
All right. You.
And let me write that down. Tomorrow, 2 p.m. SRNA class. Okay. So I would review, like I said, before I take chapter 7 test, I would review collecting urine sample, rectal temperatures,
Sounds good.
and what's one serious problem that may result in a restraint use? So restraints are things we use, like we would restrain someone in bed with them.
Bruising.
Yes. Or pressure injury, maybe,
Okay.
from constantly rubbing. All right. You're good to go. Y'all have a good evening. Call me if you have any problems or text me. I'll be here available to you this evening.
Thank you so much.
You're welcome. Y'all have a good night.
You too.